afternoon. Everyone, are you okay? Still okay? Still awake? Okay, after dietitian talk about the food, prof talk about the psychosocial, then we go to the next. Over here, we want to talk a little bit about stool. After food, we have or poo. Okay, so I'm Ho, dietitian from Institute Cancer Negara. Thank you for NCCM for having us today to sharing a little bit about the practice in the camp. Okay, so nutrition approach in ostomy management quite new. Okay, for stoma actually created after colonal surgery. Okay, there is a small opening at the surface of the abdomen to let the feces to come out from our body. Okay, so just we make it simple. Normally we have ileostomy and colostomy, and then this is the target that or the site that we have. Usually we are asked, especially for outpatient, some of the setting we didn't have any surgery or operative record. So we will ask the patient, where is your stoma? Right side, left side. So from there we can estimate which kind of stoma the patient have. Okay, so the target output for different stoma will be the difference, and the consistency or the pattern of the poo-poo will be different as well. Okay, so how about NCP that Betty already mentioned just now? Okay, MNT, for this ostomy management for dietitian, we try to optimize the energy and protein intake to improve or to promote wound heal, to improve the stoma output and consistency. Okay, prevent stoma blockage after surgery, then minimize the unpleasant output. Most of the patient very concerned about the output. Suddenly the poo-poo is come out from front but not the back. The color, the smell, the volume all in the consideration. Okay, from here the challenge that dietitian face in the ostomy management usually will be high stoma output, electrolyte imbalance. The patient will come in after discharge from the ward, readmission due to a high stoma output, watery output, and inadequate energy and protein intake, then malnutrition. These 3 points that we try to figure out in our management. Okay, for NCP, as usual, for cancer patient or even after surgery, we will have the high protein, high calorie diet, but ostomy management, we add in one more ingredient, low fiber. Okay, on top of that, we have ONS, like Betty mentioned before. Okay, so for ostomy management, usually we are encouraged for the solid food and dry. Low fiber, high protein diet for at least 8 weeks after surgery. Eat more and frequent meal. Drink more frequent to replace the water that come out from the stoma. Okay, to maintain the hydration. Eat slowly and chew your food well. Usually, if the patient doesn't chew well, the shape or the pattern of the food they swallow, it will come out in the stoma. Usually for female patients, actually not much problem in this chapter, but in male patient, they will usually not much patient in terms of having a makan. Okay, so some of the uncle will come back and then told me, I see my telur come out over here. Okay, some of the patient will, I have my tauge and then half inside, half outside, and then I have to put out. Saya perlu tarik. That's the thing that the chew well is very important. Okay, so limit free of beverage in the small amount to reduce the pressure. Eat mostly bland or less spices diet. Okay, we will ask the patient at the first stage, usually 6 to 8 weeks after surgery, try to limit all those high spice, especially in Malaysian cooking methods. Okay, masak kurma, curry, tom yum, asam pedas. Well, that's the thing that they need to cover up. Okay, then monitor after you eat. We'll ask the patient, don't just focus on your food or the way you eat. Try to monitor your poo-poo. How fast it come out? What is the shape? What's the volume? Then we try to manage that. Okay? Okay, other than that, try to avoid high fiber food. Some of the patient or most of the colon cancer patient, they have a little bit food table. They need to have a healthy diet, high fiber, multi-grain. Okay, that's before or even maybe after, but not just after stomach creation. For this, you have to avoid to control your stomach output. Okay, that including multi-grain, raw veggie, broccoli, cabbage, and the skin of the food. Okay, other than that, other than volume, some of the patient complain of my stomach become balloon, especially overnight. When I sleep, I clean already. Means I clean already, I bersihkan already. And during midnight, I awake, my stomach become balloon already. That's still fine. I'll eat. Letup. So the patient, and then they come in, complain. Okay, so try to limit all those increase the gas production. Okay, juices, a big no-no for the fruit juice. Okay, gassy drink, tea, coffee, and for those non-Muslim, alcohol, no. Okay, so what's new? Just now that I mentioned before, the patient usually the three problem will be high stomach output, watery, and then they will try to control their oral intake. Although the appetite is there, they don't want their stomach output to be large, to be watery, to be balloon. Okay, they try to control their food intake. At the end of the day, will be electrolyte imbalance, malnutrition. That's the thing. Okay, so over here, we try to share a little bit the case report that we've done in IKN with lower GI surgeon. For this patient, it come in after starting on chemo, the stomach output become very high, more than 2 liters a day. Okay, and then admitted. Then together with the surgeon and multidisciplinary approach, pharmacy, physio, dietitian, okay, pharmacy will start on the anti-motility, anti-secretion, like Lomodil, etc. Then from the dietitian point of view, we try to feed the patient to optimize back the nutrition status. So high protein, high calorie, low residue diet with oilness, but still the stomach output remains high. So boss will be, okay, lower GI surgeon decide, okay, we off orally, continue for the drug. Dietitian, sorry, you have a rest first. We start on TPN. Okay, so yes, the stomach output, is it controlled? But is it the final way we manage the patient on TPN forever? No. We try to introduce back the diet step by step. Okay, so over here, we will think about, is it standard formula is not so suitable for stoma patient or ileostomy patient. So we start on the semi-annual. But ends up, the patient not comply because of the unpleasant taste. Okay, so ends up, we try to have standard ONS, the standard complete polymeric formula we add on PHGG inside this. PHGG partial hydrolyzed guar gum in the ONS, and then we see Because most of the patient complain after I drink dietitian ONS, the stomach output will increase. Salah dietitian. So we try to figure out. I want you to drink the formula. You need to drink the ONS because oral intake is not so enough, not up to the standard. We need to integrate with the ONS. And then at the same time, we would like to control the stomach output and stomach consistency. Guar gum we add in. Then ends up stomach output control, taken off. You can see the energy and protein from the diet itself increase at the end of the day. Okay, next. This is after surgery. After surgery, as usual, try to start orally. Okay, so when we want to start, surgeon already come in and remind dietitian, we want to start diet. Please bear in mind stomach output. Don't just monitor oral, but try monitor about poo-poo. Okay, so for this case, we try to start the diet first and then we monitor first, but not straight away in the BHGG. In the ONS, okay, we'll see the output start increase when they try to increase oral intake. Over here, dietitian every day see the patient, baby, we nag on the patient, please eat. Then they try to increase. Then what happened? The stomach output increase. At this time, we try to add in BHG in the ONS to help to increase the adherence of the ONS among the patient. After we add in stomach output, start to control. At this time, the Lomotil, Loperamide, all those maintain the same. Okay? Then after that, we can see about the energy and protein increase day by day. Okay. So from that case report, we try to have a pilot study. Is that BHG helps? Is it we can implement in our clinical practice? Is it we can help the patient to comply with the ONS? Okay, so we try to have a pilot study with a multidisciplinary approach, regular monitoring by multidiscipline, means a surgeon, like help, nursing, all those things. So at the same time, we add on BHG in the ONS to help the patient to comply with the ONS. Then here's the result. For the Bristol stool chart, for the intervention group, you can see the consistency of remain type 5 and type 6. Then all those like control or the standard care, we didn't have any. We just monitor them with a multidisciplinary team and without any BHG supplementation. We see the type of the stool will be more watery. Okay, and this is the stomach output. For ileostomy, we target 500 per day, and BHG helps in this chapter. Okay, from here we can see the insoluble fiber and the soluble fiber will be different role in the stomach management. We try to monitor or try to limit insoluble fiber, but soluble fiber, maybe there will be a green light during our MNT. Okay, so multidisciplinary team and the dietitian regular monitor try to intervene and add on the guar gum. Okay, for the guar gum, this finding actually is in line with the scoping review that did by the Mitchell. The soluble fiber has a positive outcome when we manage the stomach output. Okay, conclusion, education, nutrition education. In addition, we try to have the individualized planning. Okay, ONS, monitor the intake, the adherence, and then the outcome of in terms of clinical outcome, multidisciplinary approach and follow up, and like Prof. Chan just now mentioned, psychosocial. Okay, Here is my reference. With that, thank you.